Tissue damage and injuries. The content within this PowerPoint corresponds with Chapter 6 in the Foundations of Athletic Training, Prevention, Assessment, and Management text by Marcia K. Anderson and Gail P. Parr. How do injuries occur? Injuries can occur from different events, either large or small. Acute injuries occur from rapid onset resulting from a macrotraumatic event such as the picture on the left of the University of Tennessee football player. As a side note, this football athlete, the one in the orange jersey, has had a very large macrotraumatic event injuring his knee. His entire lower leg is bent the wrong way. This resulted in fractures and dislocations of the knee. This type of injury frequently happens from one incident, and the patient can usually tell you exactly what happened, when it happened, and how it happened. We can also have injuries which occur over much longer periods of time. These are typically referred to as chronic or overuse injuries. Chronic or overuse injuries develop over a period of time from a series of microtraumatic events. Many of us have experienced low back pain, such as the pain exhibited in the picture on the right. Many times you can't distinguish exactly when it started hurting or what brought on the pain. You just know it hurts. Approximately 80% of people will experience low back pain in their lives, and for the majority of people, eventually over time, it just resolves itself. However, that can't be said of all chronic injuries. So, which one's worse? The simple answer, if you're the one in pain, they're both terrible. Acute injuries hurt because of a large force or traumatic event. We know exactly what happened, how it happened, and why. Chronic injuries are typically a little less painful, but the pain lasts for a much longer period of time. It can be very difficult to treat as it's hard to determine exactly how it happened or why. The way we treat these two types of injuries varies greatly, but is something we will continue to discuss and explore during this course. So again, how do injuries happen? We start with tissues. This could be a muscle, a tendon, a ligament, a bone, a joint capsule, or other types of tissue. When forces are applied to the tissue has one of two responses. It can either adapt to the forces that are being applied to it, or it can fail. If the tissue fails from the force that is being applied, then we have a disruption of the tissue, which is how we get injured. So every time a football player gets hit during a game, why doesn't he get injured? He has muscles, bones, tendons, ligaments, and other tissue, and all of those tissue are being subjected to forces. So why don't they get injured more often? To examine that, we need to look at several factors that can contribute to the risk of a force resulting in an injury. Number one is the magnitude of the force. The magnitude of the force has to do with how large the force is that you are being struck with. For example, you have a better chance of surviving being run over by a bicycle than being run over by an automobile, although granted, neither one is a good option. The car has much more force potential and therefore could have a greater magnitude of force. In addition, the car can also travel at a greater rate of speed, which could increase the magnitude of the force you're being struck with. Number two, the moment arm of the force. The further away from the axis point in the human body, that is typically the core, the less force is needed to injure structures. Number three, the direction in which the force is applied. Typically, a perpendicular force or a force which is at a right angle or a 90-degree angle has the greatest amount of force potential. If a ball is thrown at you and hits you directly from a 90-degree angle, it hurts a lot more than if it glances off of you from a much shallower or much deeper angle. Number four, the magnitude of stress produced. The stress produced by a force depends on the surface area over which the force is spread. For example, force gets spread over a larger area by football players who are wearing shoulder pads. If that shoulder pad was not being worn, the force would be directed over very small areas and thus increasing the chance of injury. Number five, the properties of the tissue. Muscle, ligament, tendon, and bone all react differently to forces and stress. Muscle is a lot more elastic than bone, and thus can deform and retain its original shape. Bone can withstand large amounts of force but does not have a lot of elasticity, which is great for holding us up, but bad for when the force exceeds the bone's capacity to withstand it. The mechanism of injury. You will see the abbreviation MOI used throughout the rest of the slides for the rest of the semester. The mechanism of injury is important as we need to determine the type of force that is used to create the injury. A compression force is an axial loading that produces a squeezing or crushing effect. The weight of the human body constantly produces compression on the bones that support it. If you think of your spine, the discs are compressed between the vertebrae every time you sit up, stand up, you take a step, or move. Tension is an axial loading in the direction opposite that of compression. Tension is a pulling force that tends to stretch the object to which it is applied. This may feel good to start. Pulling on tissues is a common practice of massage and physical therapy. However, too much tension will disrupt the tissue and can actually result in tissue separation. Tension used to be a form of torture, placing people on the rack. They would place tension on the arms and legs until the joints actually separated and the soft tissue did too, eventually pulling the person completely apart. Shearing forces act as parallel or tangent to a plane passing through an object. When a person stops quickly and the muscles of the quadriceps and hamstring are not strong enough or do not activate quick enough, there's enough force for the anterior cruciate ligament or ACL of the knee to be sheared off of the femur by the tibia. This is referred to as a non-contact ACL injury. So if you've ever been watching sports and you see somebody all by themselves fall to the ground and clutch their knee, there's a good bet that this type of injury has occurred. A bending force is one in which the one side of an object tries to come together. Every time you bend over in the morning to put your shoes on, you are creating bending forces in the spine. Now the spine is okay with this bending force, but what would happen if this occurred to your arm? The forearm wouldn't like it and would either have to adapt or fracture. Torsion forces are rotating in opposite direction from each other. The body does not respond very well to torsion forces. When teaching individuals how to lift properly, the technique is always to lift with the legs, keep the object as close to the body as possible, and move the entire body. Do not twist. Twisting results in torsion types of forces. It doesn't take very much torsion to injure body tissues. Combinational or combined forces. Any combination of the aforementioned forces, this could be torsion with a compression or shear with a torsion, is considered a combinational or combined type of forces. The combined force typically results in very complicated injuries, such as that of the University of Tennessee football player, which we saw on a previous slide. Muscles act like a rubber band. They have elastic properties. We can stretch muscles in much the same way you could a rubber band in between your two fingers. We can deform that rubber band by stretching it, and when we bring our fingers back together, that rubber band will retain its shape. However, our muscles in this rubber band have what's called a yield point or an elastic limit. At some point, when we stretch this rubber band, we're actually going to cause it to break. And we have the same type of issue with the muscle. Eventually, it reaches tissue failure and the muscle no longer has that elastic property. It's referred to as a plastic property. So the muscle has actually been deformed and will not regain its shape. Different types of joints can be classified in two different ways, structural and functional. A structural classification of joints focuses on the material binding the bones together. Functional joints are classified by the amount of movement that they have. For example, a fibrous joint is the same thing as a synarthroidal joint. A cartilaginous joint is the same thing as an amphiarthroidal joint, and a synovial joint is the same thing as a diarthroidal joint. This table may be helpful to individuals who are new at joint classifications be able to learn the difference between functional and structural categories. Again, the functional category refers to how much movement is available at the joint. A synarthrosis joint has no movement. The structure category and type then is a subcategory of the functional category. The fibrous, we have a suture which occurs in the skull bones. When we're very young, these suture joints are actually pretty mobile. As we age, these sutures fuse together and become a very immobile joint. This is a good thing. We do not want our brain being able to move within the cranial bones. We also have glomphus. These are synarthroses that bind the teeth to the bony sockets of the maxilla and mandible. We would not want our teeth floating around while we were trying to eat. A cartilaginous or synchronosis joint is a rigid cartilaginous bridge between two articulating bones. We see this at the vertebrosternal ribs, and the sternum is also a synchronosis joint. A bony fusion. A stenosis is where a totally rigid, immovable joint is created when two bones fuse. We also have ampiarthrosis, which have little movement. We have a syndesmosis joint, which is where the bones are connected by a ligament. We have this example as the distal articulation between the tibia and the fibula. We also have a cartilaginous or symphysis joint. The articulating bones are separated by a wedge or pad of fibrous cartilage. The articulation between the two pubic bones, or the pubic symphysis, is an example of a symphysis. Diarthroidus or diarthroidal joints are freely movable. These are the joints that most of us are the most familiar with. They're considered also synovial joints. Diarthrosis or synovial joints permit a very wide range of motion than do other types of joints. They're typically located at the ends of long bones, such as those at the arms and the lower limbs. The fibrous or synarthroidal joints. These are held together by fibrous tissue and immovable joints. These are the sutures and the glomphus again. A cartilaginous or ampiarthroidal joint is united by hyaline cartilage or fibrocartilage. They're slightly movable. Examples are the sternocostal, manubriosternal, intervertebral, and the pubic symphysis. Synovial or diarthroidal joints. These are the most common and are predominantly seen in the limbs. These are freely movable joints. There are several subcategories of synovial or diarthroidal joints. The first one is a plane joint. These are two flat surfaces which glide upon each other. Some examples of plane joints are the facet joints in the spine, the acromioclavicular joint in the shoulder, and the intercarpal and metatarsal joints in the hands and feet. A hinge joint is the second example of a synarthroidal or synovial joint. A hinge joint has one concave and one convex surface, which allow for the movements of flexion and extension. Examples are the elbow joint and the interphalangeal joints. A pivot joint is a rounded end that rotates within the sleeve-like bone. Examples are the atlantoaxial joint, the proximal and distal radial ulnar joints in the elbow. The condyloidal joint is a concave and convex surface that move reciprocally. Examples are the radiocarpal joint and the metacarpophalangeal joints. Saddle joints are biaxial joints that are saddle-shaped. The example is the carpometacarpal joint in the thumb. A ball and socket is a spherical head and a cup-like socket. An example is the shoulder joint and the hip joint. These are pictures of the different types of synovial or diarthroidal joints. The top left is a hinge joint. There's one concave and one convex surface that allow the motions of flexion and extensions. This is a picture of an elbow. The top right is a pivot joint. We have a rounded end which rotates within the sleeve-like bone. This is a picture of the atlantoaxial joint. The middle left is a saddle joint. This is a biaxial joint that is saddle-shaped. This is the picture of a carpometacarpal joint of the thumb. The middle right is a condyloidal joint. This is a concave and convex surface that move reciprocally. The picture is of a metacarpophalangeal joint of a finger. The bottom left is a ball and socket joint, the spherical head and cup-like socket, and this is a picture of a hip joint. The bottom right is a plane joint or a condyloidal joint. We have two flat surfaces that are gliding upon each other. This is a picture of the acromioclavicular joint in the shoulder. Synarthroidal or diarthroidal joints have 5 key features. Number 1, they have articular cartilage. Number 2, they have a synovial cavity. Number 3, they have an articular capsule. Number 4, synovial fluid. And number 5, reinforcing ligaments. Some synarthroidal or diarthroidal joints also have articular discs or labrums, which are flat cartilaginous pieces that sit within the joint capsule. The classification of injuries. We will be discussing each of these in more detail. The classification of injuries includes soft tissue injuries, which has subcategories in skin injuries, musculotendinous injuries, as well as joint injuries, bone injuries, and nerve injuries. The skin anatomy. Most of us, when we look at the skin, we're looking at the epidermis, which is the outer layer of the skin. We have an underlayer of the skin called the dermis, and underneath that there is a subcutaneous tissue. When we're talking about skin injuries, it may involve the epidermis, which is the outer layer, or it could involve the dermal layer or the subcutaneous tissue underneath. When we look at skin injuries, it's helpful to use the acronym APAIL to look at open wounds. Abrasions are skin scrapes due to shearing forces. A puncture is when a sharp cylindrical object penetrates the skin, such as a nail going through the skin. An avulsion is a severe laceration or complete separation of the skin. An incision is typically a clean cut, and a laceration is an irregular tear. We also have things like blisters and skin bruises. Blisters are when we have a friction type of injury, typically on the epidermal or maybe the dermal layer. We have two surfaces of the skin tissue that are actually rubbing on each other, creating friction. This creates an accumulation of fluid, sometimes including blood. A skin bruise is bleeding underneath the skin. Most of us have seen a skin bruise. Musculotendinous injuries. These include muscle cramps and spasms, muscle contusions, strains, tendinopathies, which include tendinitis, tendinosis, and tenosynovitis, and heterotopic ossification, also known as ectopic calcification, which is formerly known as myositis ossificans. We will discuss each of these in further detail. Muscle cramps are painful muscle contractions that are due to electrolyte imbalance and muscle fatigue. These can be due to dehydration, improper nutrition, improper warm-up. There's been some debate regarding pickle juice and mustard as treatments for muscle cramps. Science has suggested that the vinegar that is in pickle juice and mustard may help prevent muscle cramps. Pickle juice is currently being marketed as an electrolyte solution much the same way as Gatorade. Further research is still needed to determine whether or not these are viable solutions to help treat muscle cramps. A muscle spasm is a painful muscle contraction that is caused by a reflex reaction. When a muscle is exposed to pain, a strain, or an unexpected force, it spasms as a protection mechanism. When the muscle spasms, it tends to cause more pain, which causes the muscle to further spasm. This is known as the pain-spasm cycle. Musculotendinous injury, muscle contusions. The MOI is an acute or direct blow. It's usually from a compressive force. Ecchymosis or bruising is often present and can be very painful. A hematoma is an accumulation of blood underneath the skin. It often affects large muscles, such as the picture on the upper right, which is a picture of a hematoma underneath the skin for the biceps. It can also include large muscles like the quadriceps, especially the vastus medialis. The picture on the lower left is a picture of a quadriceps contusion. The picture on the upper right is a new contusion. We can tell it's new by the coloring. When contusions are new, they're typically bright red or almost purplish. As they start to heal, they turn kind of a yellowish-greenish color, such as the picture on the bottom right. Musculotendinous injuries. A strain is a stretch or tear of a muscle or tendon. It's easy to remember a strain is for a tendon because they both have the letter T in them. Most commonly, this occurs at the musculotendinous junction or a muscle belly. We have 3 different grades of muscle strains. Grade 1 is a stretching of the muscle fibers or micro tears. Grade 2 is a partial tear, and grade 3 is a complete rupture. As we grade muscle strains, we can see that different events occur. In grade 1, our patient is most likely just to experience pain. With a grade 2, they're going to have pain, but they're also going to have muscle weakness. In a grade 3 strain, they're going to have pain, weakness, and a loss of function. Musculotendinous injuries also include tendinopathies or any tendon pathology. The MOI is insidious, which means this comes from an overuse. It's usually from a chronic condition. There are 3 types of tendinopathies. Tendinitis is the inflammation of a tendon. Tendinosis is the degeneration of the tendon itself. These are more susceptible to partial or full thickness tear ruptures. A tenosynovitis is the inflammation of the synovial sheath surrounding the tendon. An example is de Quervain syndrome. You can tell if you have de Quervain syndrome if you put your thumb inside of a fist and then you ulnarly deviate your hand. If you have pain on the radial side, there's a possibility that you are susceptible to de Quervain syndrome. These are common in the hands and feet. The picture on the lower right indicates a tenosynovitis, a tendinitis, and a tendinosis. A jumper's knee or pain at the patella tendon is one of the most common tendinopathies that occur in the body. We also have heterotopic ossification or ectopic calcification. This was previously termed myositis ossificans. This is the formation of a bone or cartilaginous tissue within a muscle belly, fascia, or the muscle itself. The mechanism of injury is insidious, which means it occurs over a period of time, but it typically occurs after an initial trauma. This could be due to repetitive hits. This is very common among soccer players who get kicked repeatedly in the back of the leg or in the shin, or in football players who are repeatedly hit either on the quadriceps or on the forearms. The picture on the upper left is of a lower leg. There is a picture of a calcium deposit within the gastrocnemius muscle of the calf. The picture on the lower portion of the screen is an X-ray of the myositis ossificans within the distal calf and Achilles tendon. Joint injuries, we have sprains, dislocations and subluxations, osteoarthritis, and bursitis. We will discuss each of these in further detail. Joint injuries. Sprains are stretch or tears of a ligament and or the joint capsule. The mechanism of injury is the joint is forced beyond its normal anatomical limit. Grade 1 of a sprain is a stretching or micro tearing of the ligament and capsule. Grade 2 is a partial thickness tear. Grade 3 is a complete rupture. You will notice the grading scale for a sprain is much the same as a strain. Remember, strains deal with muscles or tendons, T for tendon. Sprains are for ligaments and the joint capsule. Joint injuries, dislocations, and subluxations are very similar, but their definition is very different. A dislocation is the complete separation of 2 adjacent joint structures. The mechanism of injury is acute. Typically, it is passive stretching of the joint beyond the physiological capacity of the capsule and the ligament. In first-time dislocations, we need to treat these as fractures. We never try to reduce it. If somebody is a chronic dislocator, they may be able to relocate their own limb themselves or with the help of somebody else. But we want to make sure that we get an X-ray if this is the first time that they're ever dislocating to make sure that we're not compromising vascular integrity. A subluxation is a partial separation or a joint that dislocates and spontaneously reduces itself. The mechanism of injury can either be acute or chronic. It's overloading of a joint in a position of little static or dynamic stability. A lot of times our patients will complain that their joint just feels unstable. Osteoarthritis is a chronic degeneration and softening of the articular surfaces. The mechanism of injury is insidious and chronic. It could be related to a previous trauma, for example, an ACL tears. Approximately 80 to 95% of individuals who have torn their ACL will develop osteoarthritis at some point in their life. Most of the time, this results in joint replacement. This most often affects the weight-bearing joints such as the knee. It's also common among the wrist and ankle. Joint injuries. Another example is bursitis. Bursitis is the inflammation of a bursa. This can either be from an acute direct blow or an insidious or overuse injury. The bursa are fluid-filled sac that reduces friction between the muscle, the tendon, or the ligament. And they also help to facilitate a smooth motion of the joint when the body is moving. Bursitis can either be chronic or acute. In the picture on the left, we have targeted the most common places for bursitis to appear in the knee. We have the suprapatellar bursa, the prepatellar bursa, infrapatellar bursa, and the pes anserinus bursa. The most commonly affected is the prepatellar bursa. This can get inflamed when people are kneeling for long periods of time, such as those that clean the floors or do tiling work. This prepatellar bursitis is also known as housemaid's knee. The picture on the upper right indicates an Achilles tendon bursitis. You can see the significant amount of swelling. This swelling may occur very rapidly or could appear over a period of time. Bursitis of the elbow is the picture on the lower right. You can tell that it looks like there is a structure within the elbow. That is the swollen bursa. Most of us never even know that we have a bursa until it becomes inflamed. Bone injuries. These include bone bruises, fractures, which disrupt the continuity of the bone, and we have different types of fractures, either closed versus open. There are many types of fractures. The most common is a simple or compound fracture. A simple fracture is also called a closed fracture. This is when there is no open wound in the skin. Sometimes these can be difficult to determine because the bone has not pierced through the skin. Simple fractures include a green stick fracture, when the bone is bent and is not completely fractured, a transverse fracture, when the break is across the bone at a right angle, an avulsion fracture. This is where there is a separation of a small fragment of the bone near the attachment at the ligament or tendon site. Oblique fracture. This is where the fracture is at an angle and the bones stay at an alignment. An oblique displaced fracture. This is where the fracture is at an angle, but the bones do not stay at an alignment. A comminuted fracture. This is where the bone has fragmented into multiple pieces. A segmental fracture. This is when the fracture occurs in two parts of the same bone. And a spiral fracture. This is when a bone's fracture occurs at a torque or a twist. This type of fracture is common during activity where one extremity is planted. A compound fracture is also called an open fracture. This is when the bone breaks through the surface of the skin, but it does not necessarily mean that it will stay there. Some compound fractures move back into the wound so that it is no longer visible. I do have to warn you, some of the content that you're about to see may be graphic. We need to discuss these types of injuries so that you can better understand what we are dealing with. Bone injuries. It's very important for the fractures that you understand and know the different types of fractures that we have previously discussed. Please examine the figure 6.13 on page 151 in your text. It is important that you know this information as it very well may show up on an exam. Salter-Harris injuries occur to young individuals whose growth plate is not fully fused. Salter-Harris is a classification of these epiphyseal types of fractures. we have a normal growth plate on the far left. A type 1 Salter-Harris fracture goes straight across the growth plate. Approximately 5% of fractures are type 1. Type 2 is above the growth plate. 75% of fractures are type 2. A type 3 is lower or below the growth plate. 10% of all fractures are type 3. Type 4 is to or through or transverse through the growth plate. Approximately 10% of fractures are type 4. Type 5 is the most complex. This is erasure of the growth plate or crushing type injury. It's very uncommon, and only about 5% of fractures are type 5. The higher the classification, the greater the risk of complication and the worse the prognosis for the individual. If the growth plate is fully damaged, an individual may end up with one limb that is shorter than another. This may not be as big of a deal in the upper extremity, but could pose a major issue for a lower extremity injury. Type 2 is the most common. About 75% of Salter-Harris fractures are type 2. Bone injuries include stress reactions and stress fractures. A stress reaction is an irregular surface of the bone due to the altered bone metabolism. If you felt right now on the shaft of your ulna, the outer side of your forearm, and just run your fingers down it, you will probably find that you don't have a perfectly smooth surface. The same thing for the tibial spine. So if you run your fingers up and down the front of your tibia, the front part of your calf, you're probably going to notice that you have little indentations. These are stress reactions. As an adult or as a child, you've probably bumped into many things in your life. As you have bumped into things, the bone actually creates this metabolism to try to heal itself. Stress fractures are types of incomplete fractures due to repetitive stress. These are very common in the lower extremities. They can be very hard to diagnose, but the biggest distinguishing factor is people will describe pain that wakes them up at night. X-rays, unfortunately, are not very reliable for diagnosing stress fractures. Unfortunately, stress fractures only show up on X-rays about 6 to 10 weeks after the injury has occurred. We can see in the picture on the upper right, this is a foot with a stress fracture through the second digit, indicated by the red arrow. It does not show up on X-ray until there's already a bone callus formation that is healing the stress fracture. We can also see this on the picture of the lower left, which is a picture of the femoral neck. This is the hip. There's a stress fracture there, and it only shows up on X-ray once the bone has started healing. The picture on the lower right is an MRI of a stress fracture through the neck of the tibia. This shows up a little bit earlier than on X-ray, so MRIs or bone scans are suggested if a stress fracture is suspected. Nerve injuries. We have peripheral nerve injuries. The mechanism of injury can either be acute or insidious. A compression type of nerve injury can happen when the two pieces of the nerve are forced together. An example of this is the tarsal tunnel syndrome in the foot. Nerves can also be stretched, placed under traction, or contused. An example is what's commonly referred to as a stinger or a burner, which is essentially a brachial plexus traction or compression injury. We can also get a transection of the nerve, which is where the nerve has been lacerated. Nerve injuries can be very difficult to deal with. It is important to understand the terminology related to nerve injuries. Hypoesthesia is a reduction in the sensation. Hyperesthesia is a heightened sensation. Paresthesia is a sensation of numbness, prickling, or tingling. Neuralgia is a chronic pain along the nerve's course. This can be due to irritation or to damage of the nerve. A neuroma is a mass formation around the nerve. We can see a neuroma in the picture on the bottom left. Number 1 in the picture is a swollen digital nerve. Number 2 is the Morton's neuroma. This is a growth or benign tumor of nerve tissue. Typically, this will have to be surgically removed. Number 3 in the picture is branches of the digital nerve.